All right, I would just go ahead and get
All right,
started,
so you guys want
Rob.
to start? So what is the
I want to
topic?
know.
Go ahead, Sarah.
She has been practicing this all night.
She does it every time.
I want to know why Dante has a Berlin, an external VAD, instead of an internal. Greater vortex.
There was a lot of discussion about that. I was hopeful that he could have implanted VADs as well, but Frank Pagani was pretty confident that we wouldn't be able to fit them both in. Because we knew he had to have BiVADs.
So they couldn't put only because it came from adult, they couldn't put a BiVAD vortex in there?
It's really narrow.
They said that it wouldn't fit. He was too small. They couldn't get both devices into the chest cavity and have them fit comfortably without causing undue stress. So he felt that we wouldn't be able to get them in successfully. So he said, I think you need to do the paracorporeal pump. That's how he ended up with them. Our original intention was to try to get HeartMate 2s in. That's what I wanted to do, was put 2 HeartMate 2s in. And frankly, I really wanted to just do the left side because I thought his right side would be okay. But basically, he's got sort of pervasive coronary disease. And I guess in retrospect, I'm glad that we did what we did because his myocardium is not, I mean, it's working, but not very well. And I think his RV would have failed quickly. And then we would have had to go back and put another pump in. So it's probably better that we did it together at the same time.
Right.
So given that scenario, we were, based on Frank's experience, pretty confident that we weren't going to be able to get 2 HeartMate 2s in. And so we had to do 2 paracorporeal pumps. That's why it happened. I wish we could have done it differently too, but because it limits his mobility and blah blah blah. So.
Well, are either one of our Berlins listed? They're not, right?
They are listed. They're just not active. They've got to get completely rehabbed before they can get activated, because if they are as deconditioned as they can become, then the likelihood that they're going to do well after transplant is reduced, just because of all the perioperative stuff with infection and just general weakness and lung issues when you try to extubate, blah blah blah. So we were being more cautious about getting full benefit of the VAD before we reactivate them on the transplant list. The adult people, there's a fixed 3-month waiting period after they get their pumps in until they can get reactivated, and it could be longer depending on their physical condition when the 3-month period is up. So we just went through this with the other kid. You may remember there was a teenager that we put a pump in. I don't know when that was, but we put a pump in that kid. And I just talked with them actually last week. He's at a 3-month time frame, and they were ready to get him reactivated on the list. And so their time is pretty fixed. I'm not quite as militant about the wait period, because most of the time they're putting these pumps in 60-year-old guys who have other comorbidities, and their kidneys aren't working, and their liver isn't happy, and you name it, it's not working. And I think in our population, if we get them in a timely fashion, meaning before they have liver and kidney failure, then they have probably a shorter recovery time, because they're in much better shape when they come to us. Not always, but most of the time they are. So we may not need to always wait the 3 months. And I gave him he has to meet 3 goals to get reactivated.
What's that?
Well, and they all relate to conditioning, but in different ways. I told him he had to be able to do laps around the unit on his own.
And this is Dante?
No, it's He's got to do laps around the ICU by himself. Well, I mean, he's got to push his pump. He cannot be on Vapotherm, and he's got to be gaining weight. And those were not arbitrary decisions. Those were all the elements that I thought were relevant for conditioning, to prove to me that he's rehabbed and gotten the benefit of the devices, because no point putting the thing in and then taking it out a week later and then sort of setting the kid back a whole even further than they were to start with. Then you really haven't taken advantage of the pump. So the physical walking around the unit, I at least feel like he's got reasonable muscle mass. Vapotherm means that he's got enough strength that he can keep his lungs expanded, which we all know can be a major issue in these kids. And then the gaining weight part is just because I need to get muscle mass on him, and I don't want it to be edema. I want it to be real honest weight. So, you know, we're up and down on that, but I think he seems like he's relatively motivated. Because he walked around the unit over the weekend, which nobody thought he could do.
Mm-hmm.
I didn't know.
Yeah, he went around
I
the
would
unit
have
this
never thought he
weekend.
could do.
Me
Yeah.
either.
No,
But
he
that's
walks.
the point. He can do a lot more than he shows us he can
Oh, yeah.
do.
Yeah.
And he pushed his pump and then went all the way around the unit.
Yeah.
Really?
He can do it.
Yeah. It takes a lot of encouragement.
Yeah.
I mean,
And then
It's not
he
easy
was,
to push, right?
and he was
well, we
wiped
help
out.
him push the pump.
Yeah.
We help him push it.
He was wiped out when he got
Yeah.
back to the room, but he can do it.
Mm-hmm.
And I know yesterday he was on they got him a bike, and he went around the unit with the bike.
That's awesome.
Oh, how good.
Because
And that's
of
more
his-
fun.
because of
That's
his knees,
fun.
so,
Yeah.
So that, I know he can do more than he
Yeah.
professes, but it's written on the board what the goals are that he has to meet, so. All right, you guys, what else? We got a few more people here. Wendy decided that she could wander down from the other end.
Hey, Beck, pass the sheet around so people see.
Other questions? You guys, I know you must have questions. So maybe I'll just talk for 1 or 2 more minutes.
You've only been here 6.
It's 6 too many. So Sarah brings up a good point, which is how many, there are different kinds of pumps that we have, and there are a multitude of pumps that they use on the adult side. I can't keep them all straight, but there have been multiple generations of these pumps. The Thoratec pumps were sort of an older generation. There's HeartMate 2s, there are HeartMate 3s now, which meant there was a HeartMate 1 way back when. They've gotten progressively more biologically favorably engineered, I guess is the best way to put it, meaning that they are a little bit less thrombogenic than the earlier versions were. They have more long wearing parts so that you don't have to change them out because of a pump failure. The risks of bleeding and stroke and infection are still there. There's no question about that. And they're not trivial risks, but they're not anywhere close to the degree that they were several years ago. So I guess the one thing that's good about having newer generations of these pumps is that they have a longer duration. They are more favorably contoured for various body habitus. They've made the cannulas bend a little bit more, and they've done this and that to make them a little bit more easily implanted. The driver, the controller, the controllers are a little bit more compact, and the risk of major stroke is probably a little bit less than it was, which in my mind is probably the most devastating consequence that we get from these things. You can get infections at the driveline sites and any of the other perk sites that are there, so that's always going to be a potential issue. You don't want the pump to get infected, but I think more risk, and what we see for sure with our pumps, is that there's high risk for forming thrombus and those things, and then having it go off the people that have strokes. So the pumps are better than they used to be for sure. In pediatrics, I don't know if you guys are aware of this, but there's something called the pumpkin trial, which is pumps for kids, infants, and neonates. That's why it's called pumpkin. They have a catchy name because it's a kid thing, but maybe 8 or 9 years ago, there were 5 NIH grants that were made available to 5 centers around the country to design from scratch a pediatric pump. Because right now, in those days, Berlin was still in trial mode, so it hadn't been released yet, and there were no other pumps for kids. So we basically didn't have any option except for ECMO, or in a bigger kid to use, one of the paracorporeal pumps that they had for adults. And so there was an initiative to develop new pumps. So several centers started working on their designs, and they all were part of big bioengineering departments that were helping try to put together these pumps. And 2 of them, so there are 4 pumps that have sort of made it through all of the various stages of clinical trials. So 4 pumps are now ready to go into basically phase 3 trials, which are sort of where you take the pumps and you implant them in patients at various centers, and then you look at the outcomes and try to make a determination about with the safety and efficacy of the device that you're using. So it's very different from the way a drug trial is conducted because you don't have to have as many patients. But the 4 pumps that are available now there's 2 ECMO-like pumps, new ECMO-like pumps that are much more compact, and they don't have to be on the contraption that we have.
But how long term is that? Like, how long can you stay on that? Is it still a short? I mean,
So the ECMO ones are not going to be as long, but you can use them reasonably longer than we can use our pumps now. And then there are 2 VADs that are going to be available, and they're probably going to be the ones that I've seen right now, which I've only seen in pictures. I don't know. I haven't seen the actual physical things. The smaller versions are going to be pericorporeal pumps because you probably won't be able to implant them in little tiny babies, but there may be bigger pump sizes that you can put in bigger kids that may be implantable. But the idea of having these pumps, depending on how many of the 4 make it through this trial, will be that we'll have more options to get to use pumps in these kids, and that hopefully that will give us the availability to use different pumps for different kids if there turns out that there's a specific group of people that might benefit more from one than the other one. So the way it's supposed to work is that there's going to be several centers chosen, several pediatric centers that are going to be chosen in the country that are going to participate in the first phase of this trial. There'll be a smaller number of centers that do that, and they'll each get to use one of the ECMO circuits and one of the pumps, and they'll randomize them between the patients. And that'll be done in each of these centers so that there'll be equal ability to use both ECMO pumps and both VAD pumps in kids. And then they'll probably add on more centers as time goes on so that we can see what the outcomes are of using these pumps in these kids. If all goes well, we could potentially have at least a couple, if not more, new VAD or ECMO pumps that are available for use in kids outside of Berlin and the standard ECMO circuits that we have now. It depends on how the trials go, and they've done a lot of animal model experimentation, things like that, so we know in animal models they work well. We do not know that in the humans yet, so that's still going to be a big hurdle that we have to get over. But it could give us more options. And this, we just filled out all the paperwork to be one of the primary centers for that trial. So we'll see how that goes. If we're not one of the primary centers, then likelihood is we'll be one of the secondary add-on centers over time. So it's always a bit of a Chinese fire drill when we have a kid that comes up on a pump. Everybody has to learn more. Although everybody has done remarkably well with the Berlins. I mean, it's been as if, yeah, we can do this now. And I think we'll get to that point with whatever pumps become available from this trial that's being done. But the problem that we have on the adult side is, they've got how many pumps that are out there. I can't keep them all straight, and every time, and the surgeons say, well, why don't we let's just put this one in, and I don't know what they're talking about. So then we have to relearn fortunately the general principles of how these implanted pumps work, because the majority of them now are axial flow pumps, so most of them we kind of know how they work, but it's still the individual nuances of each of the specific pumps that everybody has to learn all over again. So it'd be nice if we get sort of comfortable with a couple things that we can use pretty regularly, at least in this unit. So we'll see. Then the idea is Ming is going to be much more aggressive about putting these things in. I still don't want to use them in the post-operative patient who may just have myocardial stun that's only going to need a pump for a couple days. I'm not sure that's the target population, but we've got a bunch of others that may be able to benefit from one of those things, since we know that transplanting from ECMO doesn't go so well. And that's not just our experience, that's sort of been, that's national experience. Anyway, so that's what we'll see how all that goes, but that trial, that's going to take a few years before we get all that data.
How soon till they start?
believe, I've heard different dates. I believe it's going to be by the end of this year. I believe it's going to be by the end of this year, but it was supposed to start in 2012. So until it all gets organized, they've had to redo the whole protocol a couple times because the FDA, you have to go through this new device application process through the FDA, and it's very stringent, and they've had to redo the application a few times and the whole procedure a few times to satisfy the requirements of the FDA. I think that's done now, so now they're ready to start getting center applications to get going. So I'm hoping that later this year we'll get started. And like I said, if we're not one of the primary centers that are chosen, then we should be in the secondary tier of centers that's chosen.
Okay.
What else?
Can you explain to us why one patient has had to have his pump changed out so many times, and
I wish I knew.
you don't know why?
Yeah, these pumps, on average, the Berlins, what's reported is that they get changed about once a month. That would be pretty standard. They're all the housings and the tubings are all carnita coated, so the likelihood of making thrombus is less, obviously not zero, but it's less. And most of the time they form on the valves, the inlet and outlet valves. That seems to be where they always form. Now, he's had a special circumstance because, don't forget, he had a lot of bleeding issues up front. So he was on and off heparin, he's been off aspirin, off his percent. I mean, we basically weren't able to effectively anticoagulate him early on. And so I wasn't too upset when we had to change the first one because he hadn't been effectively on anticoagulation. But the second and third times seemed to happen with some rapidity that I wasn't sure I understood why that was happening. And we're also changing them a little bit more aggressively than we did in the past, meaning I think we would have let them sit there a little bit longer and gotten bigger and not worried about it as much. We're trying to be a little bit more proactive about changing things out if we think there's a real risk for the thing to embolize. And if it's on the outlet valve, then that doesn't have to go very far. And especially if it's growing and getting bigger, we're pretty nervous about it. So I think that part of the reason that he's had to have it changed more than we would have normally seen is, one, we've been a little bit more proactive about not letting the clots sit there and get bigger, and two, he's still not on full anticoagulation. He's only on, his aspirin's therapeutic and his heparin is mostly therapeutic, but not always, and that's probably due to his own metabolism that changes. And then his Prosantin dose has never been therapeutic, so they keep going up on that, but we don't, the inhibition that we look for on the labs has never been in the therapeutic range. So maybe it's part of that, or maybe he, for whatever reason, seems to make clots a little bit quicker. I don't know. We were a little suspicious that the last pump, which got clots very, very quickly, maybe the coating wasn't as consistent around the pump, I'm not sure, but the clots still occurred in the same usual place, which is on the valves.
Does his nutritional status play into this whole clotting issue at all?
Well, I can't say that it absolutely doesn't. The degree to which it does, I can't say. You know, if you're AT3 deficient, you can require a whole lot more anticoagulation and we see that on the ECMO circuits all the time. They just need more and more and more and more. Then you give them their AT3 and all of a sudden everything gets much better. But I don't know that that's necessarily the case for him, because his nutritional stores, while they're not good, weren't terrible, and we didn't measure things like AT3 levels, but I suppose it's always a possibility that maybe with his nutritional status, it's always a balance in your body between pro and anticoagulant factors. So if that balance shifts at all, then you're more or less likely to make clots. So I don't know, maybe there's something about his nutritional status that put him at risk. But I can't measure it, so I can't say for sure.
What's AT3, Rob?
Oh, antithrombin 3.
Oh, okay.
It's just part of the clotting cascade.
Okay, so that's what you're referring to. Okay.
And FFP has it. You can get it, you can reconstitute it and give it separately, which is quite costly. Or you can just give FFP. That particular protein is in FFP.
Okay.
Redder? I can't believe that.
Sorry, I came in the middle, so I don't know everything else.
All right. Well, we could talk about your orange sweater and your orange shoes.
She has an orange car too, you know?
Oh, and the orange car?
She has an orange car too.
I did not know
Yes,
that.
she does.
I need photos.
Oh, it's snazzy.
With
I-
you standing next to it. Your orange sweater and your shoes.
I have another question, Rob. With the way the healthcare is today, is there any glimmer of any pushback on all these ventricular assist devices and Berlin hearts and transplant 1, transplant 2, transplant 3? The whole hypoplast population?
Is that what you're asking? Who's going to pay for it?
That's sort of what I'm just wondering, is there any talk out there? Is there any
There's a lot of talk out there. You sort of hit on you've hit on one of the big issues in healthcare right now. So when you look at what drives the spending in healthcare, there's multiple areas that you can look at that will determine what drives healthcare costs and spending. And costs and spending aren't quite the same thing, but for our purposes, we'll just use them interchangeably. It turns out that new technology is probably one of the primary drivers for increasing resource utilization and cost, which then translates into spending. So it is true that all the new technology that we have can drive up healthcare costs. So yes, there's been a lot of focus on should we limit application of those technologies to try to control cost. So when you look at what healthcare economists and people that think a lot about healthcare management and how to curtail the costs that we incur with the use of these technologies, my impression from reading now a lot of literature about this is that people don't want to curtail development or use of technology because obviously it can improve quality of life, which is the reason that we do all the things that we do. And it turns out that's probably the reason that the costs go up. In general, when you have a firm in economic terms, so when you have a firm, which is like a hospital system or a business, et cetera, that creates new technology, they can more efficiently use the inputs that they have, personnel, equipment, things like that. They can use it more efficiently. And so that usually makes the cost go down. One of the circumstances where that may not be the case is when you have a lot more technology, and even though it's more efficient, the quality is improved, which means that more people will use it, and then the cost actually can go up. So that's part of what's going on, I think, in healthcare now, is that all these technological advances that we have come at a price. And it's because we are using all of them much more readily, then the cost, part of the cost issue is because of all the technology that we're using. Doesn't mean that we shouldn't use it. Probably what we should do is focus on other things that are part of that whole picture, look at more efficient ways of using that technology, more effective ways of using that technology, coming up with high risk or most appropriate target groups to implement the technology, which we're trying to do with some of these devices. It used to be in the old days they would put the device in just about anybody, and then there was a pretty high mortality in a particular group of patients who were the ones that were considered sort of already past the benefit of the device. So they ended up getting the devices, which were very costly, and then they died not too long after that with all kinds of complications. So maybe, and so there's been some shift already towards not putting devices in those patients that are already too far gone, so to speak, and reserving it for patients who we think can drive the most benefit. And that may be a better way to try to allocate these resources. Same thing with transplant. There's probably a point at which you're not a candidate anymore for transplant. It's just very difficult to recognize where that point is, particularly for the healthcare team that's been providing the care, because it may be obvious to an outsider who comes in and says, well, why are you doing this? This guy isn't going to make it through a transplant. But all the people that have been intimately involved can't see the forest for the trees because they've been very invested and they're not objective anymore. So people are trying to create and develop more objective and stringent criteria by which you make a decision about whether somebody should get a device or should be transplanted or use this technology. So I think we have a long way to go to figure out how to do that in a way that helps us contain some of the costs that we see now. And I certainly don't have the answers, but yeah, all the technology probably is contributing to the escalating cost. And there are a lot of people out there that are trying to work on strategies to bring it down. And I think it's going to boil down to trying to figure out most appropriate target groups to use the technology in, and be able to say that we're not going to use it in people who we don't think are going to drive any benefit. Some people might call that rationing, but basically in economic terms, you're trying to make sure that your so-called marginal cost doesn't exceed the marginal benefit of the technology that you're using.
Okay, thank you. Any other questions? All right, well, thank you, Rob.
You're welcome. Now, does anybody else want to talk about economics? Do you want to talk about production
No.
functions?